Ladies and gentlemen, my name is Dr. Moiz Adamji and I'm an emergency physician working with you with this channel EM2Po to make EM education lighter and a bit easier to understand. When it comes to this topic, it's my favorite topic. It's called pulmonary embolism. And I'll be talking about a few things, how to manage it, how to diagnose it, and finally, my clinical pearls of pulmonary embolism over these years of experience that I have. So, if you look at pulmonary embolism, it's often misdiagnosed. And this is because many of us do not think about it. Only a correct diagnosis in 10 to 30% of the cases. Up to 60% of autopsy will show some evidence of past pulmonary embolism, which was never picked up. Identification and appropriate treatment may often prevent unnecessary morbidity and mortality. So 90 to 95% of pulmonary emboli, they originate from the deep venous system of the lower extremities. So this is your chance of using bedside ultrasound to screen every other patient who is bedridden, having risk factors for PE, for a DVT. If you find a DVT, then you might be able to find a pulmonary embolism as well. So these are the ones that are common femoral, superficial femoral, and popliteal veins, which are commonly targeted in terms of thrombosis. The pathophysiology is simple. You have either endothelial injury or an abnormal blood flow, maybe you have heart failure, which is preventing this blood flow to the right side and causing a pulmonary thrombus, and hypercoagulability, which in certain condition is present, antiphospholipid syndrome in young patients, or pregnancy as one of the risk factors. Now, whenever you talk about pulmonary embolism, it's the blockage or thrombosis of the pulmonary artery. These are the risk factors that you can always see. There are some which are inherited and some are acquired. Most common one can be immobilization in elderly patients or surgery or trauma. In women who are young and don't want to get pregnant, estrogen therapy would be something that they're thinking about. Pregnancy is another form of risk factor that we should be thinking about. Why bothered or why be bothered? Because PE may cause dangerous physiological effects. The first one is ventilation perfusion mismatch, creating dead space ventilation and hypoxemia. So imagine you have no blood flow to that particular area. That particular area is a dead space now. There is no physiological diffusion or exchange of oxygen taking place. This hypoxemia will strain the RV, and thus the RV needs to work harder to push blood towards that blocked pipe. So now it becomes dilated, and this actually reduces the preload. It causes LV failure because right-sided heart failure can cause left-sided heart failure, and thus ultimately poor cardiac output and therefore hypotension. So this is from a low risk PE to a massive PE, depending on how large the thrombus is. Diagnostic approach, obviously, you have your labs like D-dimer, you have your ultrasound for RV strain or echo, and you have your stethoscope to check if the chest is clear. You check the heart, there is RV strain, and you check D-dimer and it's elevated, you're thinking of pulmonary embolism. Now, DVT symptoms are usually unilateral limb pain and swelling, and may also complain of heaviness or sharp pain or redness. And the signs could be a calf pain or tenderness on palpation, and erythema and superficial vein distension. If suspect DVT, the rule of thumb is that always think about pulmonary embolism. The symptoms of pulmonary thrombus embolism is number one is dyspnea, and the last one is syncope. But each one of them can present in a different way. Sometimes you might just get a syncope patient with pulmonary embolism, and sometimes you might get the rarest thing like hemoptysis, and it could be a pulmonary embolism. So just keep that diagnosis in mind whenever possible. Signs and features in patients with pulmonary Signs, the most common sign, 92% of that is tachypnea, and the last one is cyanosis, which is very late because majority of the patients probably are going to go into cardiac arrest before they even reach this kind of the sign. Chest X-ray. It's not sensitive nor specific, but you might find atelectasis, elevation of the hemidiaphragm, pleuroeffusion sometimes, dilation of the main branches of the PA, and parenchymal densities. This is one of the rare findings in the chest X-ray, which is called the Hampton's hump. As you can see, you can appreciate a pleural base infiltrates with apex towards the helium, and that's called the Hampton's hump. The Western mark sign it's like oligemia. It's lucency of the area around the large blood vessels or distal blood vessels of the pulmonary, and it will show up in the X-ray as an area of hyperlucency, and this is how you know it's a Western mark sign. So this is how you see there is a contrast filling defect on that area, and this is how you know that there is a pulmonary embolism. So CTPA is your gold standard before the coronary angiography, which we don't do anymore, but CTPA is one of the gold standards now. ECG, most common is sinus tachycardia, RV strain, which is right atrial dilation in RBBB, T-wave inversions and ST changes in V1 to V3, P pulmonale because obviously the right heart or right atrium will be enlarged, and S1Q3 is classic but not really common. You won't see it every time. So this is what we're talking about, the S1 in lead 1, T3, and Q wave in lead 3. Now, not always present, by the way. Sinus tachycardia is the most common. Now, let's talk about D-dimer. A very high specificity in patients with very low risk. D-dimer will miss 7% of cases of venous thromboembolism, only used to rule out low risk. So, the negative predictive value is around 78%, sensitivity as low as 80%, and positive predictive value as low as 30%. Bedside ultrasound, you see a dilated hypokinetic right ventricle and large right ventricle as compared to the left ventricle. That's what I do if I do a parasternal long axis view. Then when I do an apical view, I look at the hypokinesia of the RV. You might see tachypsid regurgitation, and if you are good enough in echo, you can even calculate the pulmonary arterial pressure or systolic pressure, and it might be increased in such scenarios. RV strain is a predictive of death, and that's where you might think about thrombolysis as well in such patients. DVT scan, you can do two-way compression tests. Look at the femoral, look at the popliteal, compress those arteries and see if there is compress those veins and see if there is a thrombus. A ventilation perfusion scan, you may want to do it in a patient with contrast allergies or a person with you cannot use contrast for CTPA, or a patient with a pregnant patient, maybe you might want to use a ventilation perfusion lung scan. And the higher the perfusion mismatch, the higher the chances that you have a PE. Okay. Now, CT angiogram provides alternative diagnosis, may replace angio as the gold standard. CTPA equals to image reconstruction, and overall sensitivity is 68%, while the negative predictive value is 80%. Now, let's talk about clinical probabilities of acute PE. Wells score is the common score that we use, and there are 3 tiers and 2 tier score. The 3 tier score is basically you have 3 tiers of the score: low, intermediate, and high risk. Okay, so if low risk less than 2, high risk 2 to 6, and greater than 6 is high pretest probability. And this is based on the signs and symptoms and some of the findings as per your history and examination. So let's say if you have low risk, then you might avoid the D-dimer altogether. But let's say with Wells score, I would combine the pulmonary embolism rule out criteria. This is another score. If that is positive, I'll still go back to doing D-dimer. If D-dimer is positive, I'll go to CTPA. So basically, if it's a low risk, if it's an intermediate risk, I'll do D-dimer positive CTPA. If not positive, then I'll just leave the patient and think about the diagnosis. More than 6, definitely go for CTPA and think about that was for diagnosis. Okay. Now, assessing clinical probability of PE is like this. So if you have low to intermediate clinical probability, D-dimer positive, CT negative, no treatment. CT positive, treatment. If D-dimer is negative, no treatment. High clinical probability, direct to CT. That is how we deal with the patient. Now, treatment. The treatment is supportive. You want to make sure your ABCs are done, airway, breathing, circulation. The thing that causes vasoconstriction, you need to avoid it. Hypoxia causes vasoconstriction. Hypercarbia causes vasoconstriction. And acidosis causes vasoconstriction. So whatever is causing that, you should try to treat it. Okay. If unstable, like unstable means patient is hypotensive for more than 15 minutes, systolic blood pressure less than 90, you need to thrombolize. And say if the patient arrives at cardiac arrest and a diagnosis of PE was already made by CTPA, you might want to thrombolize such patient. The HA recommends that if you have a ventricular tachycardia, then you have higher chance of bringing that patient back. If the patient comes in asystole and it's PE and you give thrombolysis, you might even do CPR for 1 hour and you won't see any results. HA does recommend doing CPR for 1 hour after thrombolysis. So that's how much time you need. And after the thrombolysis, you can anticoagulate the patient. So after a few hours, like 6 hours of thrombolysis, you can start anticoagulation. And heparin is more recommended in acute cases or critical cases. And subacute cases, you can use enoxaparin, which is 1 milligram per kg. Heparin is 80 international units stat. Then you give 18 international units per hour. And you look at the heparin chart. There is a chart for heparin. It's an APTT chart. You're looking at the APTT every 4 hours and adjusting the dose of heparin as compared to the charts. Anticoagulation that we use is heparin. Reduces mortality from 30 to 10, 30, more than 30% to less than 10%. And requires high dose. Like you can start with 80. That's what I do. And then 18 internationals per kg per hour. And you can even, and the sub-Q, enoxaparin, which is usually used for prophylaxis, normally in ICU patients who are bedridden. Low molecular weight, more effective for prophylaxis and treatment of DVT or PE, active against factor number 10 and 2A, enoxaparin or Clexane 1 milligram per kg BD, and pregnancy also you can use low molecular weight heparin. Anticoagulants that we use is warfarin, but nowadays there are newer ones which are apixaban and rivaroxaban, which does not require PT, APTT monitoring on INR to reach a therapeutic goal. So DVT, you need to anticoagulate for 6 months. If the patient has a reversible cause, consider 3 months. If second episode irreversible factor, then long-term anticoagulation, even exceeding 6 to 1 year, can be there. Thrombolytic. Now, when do you thrombolize a patient? Thrombolizing the patient is in a massive PE, unstable patient who has hypotension or appears in cardiac arrest, severe bradycardia. And on top of that, if you have significant hypoxia, for example, a patient recently came to us, it was a breast cancer patient who has significant hypoxia. We give high flow, doesn't work. We give CPAP, she's maintaining, but we are constantly requiring more and more oxygenation for her. And ultimately, we thrombolized her and she was fine and she came on the face mask and later on nasal pumps. So that would be one of the case. Or if someone has intermediate risk, which is, let's say you have RV dysfunction with myocardial necrosis, meaning troponin is positive, D-dimer is positive, these are the patients you might consider thrombolytics. The MOPED trial considered low dose thrombolytics like 50 milligrams over 6 hours. And This also depends on the Hess-Bled score. The Hess-Bled score is basically a score that tells you how high is at risk of the patient bleeding. So if it's an intermediate high risk patient, you calculate that, you see how much at risk. If they are at high risk, you give half dose, which is 50 milligrams over 6 hours. If they are not at high risk, then 100 milligrams over 2 hours. Alteplase, and I'm talking about alteplase in this case. Critical documentation features supporting diagnosis. Like, write all the risk factors that you're thinking. Signs of RV strain or ultrasound, you need to document that. And anticoagulation use, including type, dosage, time, and what time it was started. Your disposition most of the times are patients on a monitored bed, so it's either HDU or ICU patients. And take home message is PE commonly is a misdiagnosis. Use D-dimer to rule out low risk patient, and treatment depends on stability of your patient, which is thrombolysis versus anticoagulation. Now, I do want to talk about thrombolysis. So you have three types of patient: low risk, which has no RV strain, no troponin rise, no pro-BNP rise. Then we have the intermediate risk, which is divided further in low risk, which is the patient might have RV strain, but no troponin rise, no pro-BNP rise. And intermediate high risk, which is RV strain, troponin rise, and pro-BNP rise. And then we have the high risk patient, which are those who can come with bradycardia, who can come with cardiac, who can come with near syncope, who can come with also hypotension, or sustainable hypertension for more than 15 minutes. Or even when you are like having, if you first diagnose the patient with cardiogenic shock and later decided that this could be PE, and norepinephrine use is getting higher and higher, then you might think that this is an unstable patient, you might have to thrombolize such patient. So intermediate high risk patients with a good consultant who can back you up, then give thrombolytics. And high risk patient which are unstable with hypotension or cardiac arrest, you can give thrombolytics. Now, even cardiac arrest, you should think about it. I mean, why would I give a thrombolytics to an asystolic patient? If I'm giving it to a ventricular tachycardia or ventricular fibrillation patient, I know there is a chance the heart will come back. And AHA recommends doing CPR for 1 hour. So these are some of my clinical pulse. I normally do it and I follow that algorithm pathway. D-dimer is positive. If it's slightly high, I'll do the pulmonary embolism rule-out criteria. This is me. This is not in the book. So it's like I do D-dimer. Let's say it's slightly high. I'll look at the age of the patient and see whether it's meeting the cutoff. It meets the cutoff. I'm thinking, okay, let's do pulmonary embolism rule-out criteria. If the rule-out criteria says no, it could be PE, then I go for CTPA. Otherwise, if the D-dimer is significantly high, then I definitely go for CTPA because I'm killing two birds with one stone. If there is a chest symptoms, then I know I'm looking at the chest properly. And if there is PE, I'm also ruling that out. So thank you about that. And that's all I have for today. And I hope that you guys understood something. If you like it, follow me for more. Share, subscribe to the channel so that we grow together. EM Tupo.